So we request the speaker, Dr. Rajpal sir, to assume the dais. And we request Dr. Nandakumar, Joint Secretary, want to accompany Dr. Rajpal to the dais. So, to introduce Dr. Rajpal sir, who is a very well-known interventional cardiologist of the region, to say, I have had many opportunity to observe Dr. Rajpal sir's practice in Coimbatore, and he is not the person who received patients referral from region in Tamil Nadu. When I was a DNB candidate with him, at that time we used to get patients referred from Delhi. From Apollo Delhi, the patients will be referred by the consultants, cardiologist in Delhi to Dr. Rajpal for left main stenting that he does in a great way. And we cannot have enough time to share my experiences with him. And there was one instance when a 20-year-old boy who got collapsed and brought to the emergency department in a pulseless asystole. Right femoral vein sheath, and did a pacing and got the sinus rhythm. With the paced rhythm, he has gone into the left main coronaries and he has put a stent, and the patient has gone walking home. So these are all some of the magics that Dr. Rajpal does on a day-to-day basis, and he is considered to be the savior of any interventions that goes wrong in GKNM cath lab. So any intervention done by any person in GKNM cath lab, if it goes wrong, then the call to Dr. Rajpal will be given, and he will be arising to the situation as a savior, and the skills that he owns is not comparable to anyone else. So these are my experiences with Dr. Rajpal. So I was very much keen that during my secretaryship period in Erode IMA, I have to bring Dr. Rajpal sir to our Erode IMA for the benefit of Erode IMA members, so that he can give us a good talk. And Dr. Rajpal sir has finished his MD, DM, and he has underwent training in Paris. And after finishing that, he has joined JKNM Coimbatore, and he has been a senior interventional cardiologist over the region. And he was the one who has started this radial approach coronary angiogram and PTCS in Coimbatore, and the list goes on. So now I will go to the secretary report, and I request you to go through this slide. So these are the campaign.
நான் டாக்டர் CN ராஜா, இந்திய மருத்துவ சங்கத்தின் தேசிய துணைத் தலைவர். நான் தமிழ்நாடு மெடிக்கல் கவுன்சில் எலெக்ஷன் 2023 போட்டியிடுகிறேன். நாங்கள் 7 பேர் இணைந்து IMA, FACDA, ஃபாரின் மெடிக்கல் கிராஜுவேட்ஸ், டீம் ஃபார் டிரான்ஸ்ஃபர்மேஷன் என்று இணைந்து போட்டியிடுகிறோம். ப்ளீஸ் vote and select team for transformation for the betterment of our medical council, Tamil Nadu Medical Council. Thank you.
Dr. CN Raja has been involved in the campaign for TNMC election for the past 2 weeks since the announcement of TNMC election has taken place, and today he is in Namakkal IMA. So he has been very actively involved in the campaign. So the present situation that every medical fraternity faces, there is lot of threats that arises to a medical professional's life, wherein if a threat gets arisen for a medical professional, he has to be resorting to some senior person in Tamil Nadu Medical Council, and the Tamil Nadu Medical Council has to stand with a person at that difficult times. So if Dr. C.N. Raja's team has been selected and he has been given us the promise that we will get a harassment-free, corruption-free and doctor-friendly team. So the 7-member team that he has been into a part of is Dr. S. Kanaga Sabapati, a past IMA State President, and he is past Tamil Nadu Government Doctors Association State President, and Dr. C.N. Raja, National Vice President IMA, and past IMA State President, and past State President AOI, and Dr. T. Balasubramaniam, Professor of Cardiology, former Trichy Medical College, active participant in IM activities. Dr. P. Balakrishnan, DT NGDA, State President, past President TN Medical Council, and President IMA Thiruvattriyur Ennur Branch. Dr. P. Saminathan, SGPGA State President and President IMA Neyveli Branch. Dr. Syed Abdul Qadir, President of RMGA, President IMA Purasivakam Branch. Dr. Murugayan Akilan, State General Secretary, TNMOA Advisory Committee Member, Government Doctors Corpus Fund Scheme. So this is the team that Dr. C.N. Raja is contesting for the elections. We will go to the Secretary report. So as you all know, Erode IMA House, the registration process, everything is done, and first floor is occupied by Byju's, and the agreement process has been transferred to Erode IMA name, which was there with the past owner of the building, that is Mr. Mohan. So we have signed the memorandum of understanding. Erode IMA have entered the formality of process for completion of MOU with Think and Learn Byju's has been completed over the past week, and the security deposit and the 3 months rental for the month of September, October and November, the invoice has been raised by the Erode IMA towards Byju's, and we are awaiting the payment for the rent. The rental that is given by Think and Learn Byju's for the occupying the first floor as corporate office of Byju's is 1.65 lakhs a month, and even now the ground floor of Erode IMA house is vacant, and if you any of your friends or families require any good AC floor with 3,700 square feet in the ground floor, very near to the bus stand. We are in the process of letting it out for rent. So October to November monthly report. So this is what is happening very actively in Erode IMA. So TNMC election, as I have already enlightened you. So this is the team that we are, and it is very important for us to verify our address in Tamil Nadu Medical Council, because the election process is not digital, it is manual. So only if we updated our address in a correct manner in the Tamil Nadu Medical Council website, you can go to the website and verify your address. Only if you receive the ballot paper And after you receive the ballot paper, if you put the ballot, and then that has to be collected back, and that has to be sent for the election process. So this is how the election of TNMC is done. So this is the campaign that we have completed in Perundare Medical College, and over the last weeks, the campaign was completed in Erode Government District Headquarters Hospital and other main areas. And this is the 16th October 2022 CME. And fortunately, last month, we, Abhirami Kidney Care, has sponsored the event, and we have conducted a CME with the topic of kidney transplant, and we have also involved Dr. Karthik, hepatic surgeon from MGM Health Clinic, he is a hepatic surgeon, and fortunately both of us are from Bharati Vidya Bhavan, that is a local school, and Dr. Yellam Ramakrishnan, who is a correspondent of Bharati Vidya Bhavan, has been facilitated during that ceremony, and around 40 to 50 members have attended that. So this is the invite, and Dr. C.K. Saraswati Madam has also joined us for this felicitation process, and that happened in the last week. And these are the pictures of Dr. Yellam Ramakrishnan sir and Dr. Mrs. Aruna getting felicitated, and many Bharatian doctors have joined the occasion and have shared their happy memories with Dr. Yellamar sir. And this is the picture that was taken during that event, and so this is the picture. So FSS check has been handed over to family of Dr. L. Syed Isaac. FSS 1 claim amount of rupees 18 lakhs was handed over to Mrs. Ahmadi Parveen. And this is the 1068th claim of FSS 1. So this is the Erode IMA house that I was talking upon. This Erode IMA house ground floor is vacant for rent now. So now we will go on to the academic session for the night. So Dr. Rajpal, as I have already told, he has completed his DM in cardiology in the year of 1993 from Chitrai Tirunal Medical College, and he has underwent fellowship in interventional cardiology in abroad countries like Paris and Canada, and he has been the chief, that is head of the department cardiology in a very well-known center for cardiology practice, that is G. Kupswami Naidu Memorial Hospital. And now I invite him to take over the dais and proceed with the academic meeting.
Good evening, everybody. It is a pleasure to be here with the Erode IMA, and it's an honor and pleasure to be here. I thank the President, Dr. Vijay Kumaran, Dr. Saravanan, and Dr. Sendil for this wonderful opportunity, and also the senior physicians whom I have been associated with in Erode. Thank you, sir, for this wonderful opportunity given to me. It's a pleasure and honor to be here and to be part of you for this evening. Actually, I saw the hall. It's a very beautiful hall, and it's nice that IMA is, actively doing something, and you are generating funds for the institution, for the IMA, which will then become more and more independent, and you do not have to run around for anything. So this is something very nice, and even this hall is also beautiful. This hall also is beautiful and it's nice to be here. So over the next 20 minutes, I will walk you through some, I will walk you through some newer treatment modalities in interventional cardiology and how cardiology is changing, how cardiology is becoming more and more catheter based, procedures are being done. People now do not want to undergo major surgical procedures if it can be avoided, So I will talk to you about replacement of the entire aortic valve percutaneously. Before, the aortic valve, when it used to be replaced through open heart surgery, which means actually opening the chest, going on cardiopulmonary bypass, stopping the heart, draining the heart of all its blood and running entire on a CPB machine, stopping, defibrillating the heart, opening it, excising and then replacing and stitching a new valve. Nowadays, it is done routinely, percutaneously, which means it is done through the femoral artery, through maybe a 3.5 to 4 millimeter incision on the groin. The entire aortic valve is replaced for aortic stenosis, and the patient goes home 28, maybe 48 hours later. Usually he is shifted to the ICU, and in the evening he goes to the room. Next day morning he stays. Next day evening he can go home, or he can stay for one more night. Actually, when we were asked, when is the best time to be an interventional cardiologist? I believe now is the best time. We are going through a tremendous transition, and we are seeing so many new procedures coming in through interventional cardiology, catheter-based technologies which are new and working very well. So, I will just walk you through the aortic stenosis detectment strategies. So, I think all of us are very familiar with aortic stenosis. Aortic stenosis, all of us are very familiar with. There are two types of aortic stenosis, the major two types, three types I would say. One is the rheumatic aortic stenosis, which now is slowly the incidence of rheumatic heart disease in our along with the rheumatic aortic stenosis incidence is coming down. Then there is the congenital, wherein somebody has a bicuspid aortic valve, and that incidence will remain. And third thing is degenerative, that is, as we age, the aortic valve gets thicker and thicker and gets sclerosed. The incidence is dramatically increasing because we are having an aging population. More and more of us are aging. So with age, the aortic valve degenerates and slowly but surely becomes narrow. So, and as it ages, it becomes calcific. This is a degenerative disease which has a very high mortality. We are of the opinion that cancer and myocardial infarction has high mortality. That is which is true. But once a patient has symptomatic calcific aortic stenosis, then that mortality is more than the most aggressive cancer. 50% die at 2 years. So do you please understand the seriousness of this disease? Once a patient has calcific, significant, severe aortic stenosis, then the mortality is higher than of most malignancies, most aggressive malignancies. Half of them die at 2 years. And this is becoming more and more common in our country because more and more people are reaching elderly age, and as we age, this valve is going to get more and more narrow. So aortic stenosis can occur in the younger age group. If it occurs in the younger age group, it is usually congenital or rheumatic, as I spoke to you. it is congenital aortic stenosis or rheumatic. If it is congenital, usually it is bicuspid. Usually the aortic valve, all of you have seen the, you must have seen, or most of you may be riding in a Benz car. So if you are riding in a Benz car, what is the sign of Benz? Benz is that circle with three, with that three, like that. Huh? Yes, 3 wings. Yes. So that aortic valve in the normal human body is tri-leaflet. It's like the Benz car sign. 1, 2 and 3. So the 3 leaflets open. That is the normal aortic valve. But some people, it will not have 3 parts. It will have only 2 parts. Instead of opening like this, it will open like this. It will have only 2 parts. So that is called bicuspid. Normal tricuspid valve is, normal aortic valve is tricuspid, which has 3 cusps. This will have 2 cusps. Once a patient has 2 cusps, bicuspid aortic valve, then the chances of it becoming narrow with age increases with every decade. And by around 40, 45, the valve begins to narrow because it cannot take the stress. A tri-leaflet valve, the stress on the valve leaflets is low. In a bi-leaflet valve with 2 cusps, the stress is more, so it gets stenosed. Of course, that is in the younger population. The older population who present in the 6th or 7th decade, this is the classic aortic stenosis which we all see, all of us as we age, 65, 70, 75, the valve will get thicker and thicker, and it is a normal process that it will get thicker. But stenosis occurs in a limited number of people when they touch 65, 70, 75. So this is a normal leaflet. This is the aortic valve which has 2 leaflets. This is an aortic valve which has 3 leaflets. This one has 3 leaflets. So with age, aortic sclerosis develops, some amount of lipid infiltration, some amount of fibroblast infiltration, and the valve has thickened, but it is still opening well. As we age, there is the deposition of some calcium, deposition of fibrofatty tissue, and the valve begins to become narrow, and here it is very narrow with cartilage, little bone formation, severe calcium and hydroxyapatite crystals. So this is the natural history of aortic stenosis. Now, this is just to show you in context the aortic valve, atrium, ventricle, and this is the aortic valve. This aortic valve is the main valve which opens and supplies blood to the entire, if it opens, that this is the blood supply to the entire body. So this is how it looks. Healthy aortic valve is open and it closes. Diseased aortic valve opens only so much. So when the diseased aortic valve area is less than 1 square centimeter, it is known as severe aortic stenosis. So this is just to show you the left atrium, ventricle. Blood flows from the left atrium to the left ventricle to the aorta, and this is the aortic valve that we are talking about. It is calcific and stenosed. So one small thing, please feel free to stop, ask some questions, and this is a very informal meeting. Please do not hesitate to just ask. If there is a mic around, I'm sure we can pass it. If somebody has anything, please stop and we can always have a discussion as we go on. Now, what happens when the aortic valve gets narrow? The first thing is the heart, when it pumps blood, all the blood that is pumped by the heart has to go out through the aortic valve. That is the single valve. So when the valve becomes narrow, because the valve is narrow, the heart begins to pump vigorously. So what happens? The ventricular wall becomes thicker and the entire hypertrophy takes place. The wall becomes thicker and it's like you take a dumbbell and do biceps exercises, biceps will become stronger. Like that the heart muscle becomes thicker and thicker. When it becomes thicker, it is a way of compensation, but it's not a very good thing, because along with the thickness will come fibrosis, and the heart will not be able to relax well. For the heart to fill, it has to relax. If the heart doesn't relax, then it doesn't fill. If it doesn't fill, it cannot eject. So the first thing that occurs is diastolic dysfunction. And second thing, after some time, the heart gets tired. And then what happens is systolic dysfunction. That is, the heart begins to fail. In between this, patient can develop lot of arrhythmias, atrial fibrillation, patient going to heart failure, or the heart can dilate and patient can develop mitral regurgitation, the leaking of the left side valve. So the most important thing that we must understand is, as the valve gets narrower and narrower, the heart initially compensates by thickening. Even the thickening is a problem, because the thickening of the cardiomyocytes, along with the thickening, some fibrosis deposition takes place, and the interstitial fibrosis and thickening takes place. So the heart, although pumps vigorously, it pays a price. It cannot relax. So when it cannot relax, blood cannot fill, and only what fills can go out. So cardiac output immediately comes down. The most important symptoms, the three most important symptoms for a patient with cardiac with aortic stenosis is chest pain, because when the muscle gets thicker and thicker, the existing blood is not enough for the heart. So the heart, because it is thick, it needs more blood, but the existing blood supply is not enough. Patient complains of chest pain. And moreover, when the blood supply is not, when the valve is very narrow, he can develop syncope, because less blood is getting ejected. So when the patient walks, he gets up and quickly goes for a walk, the blood is diverted to his muscles, he can develop syncope, because cardiac output is fixed. The amount of blood exiting from the heart is fixed, because the valve is narrow. So in that blood, whatever comes has to go to the brain and has to also go to the muscles. So when he walks or when he gets up quickly, he can develop giddiness and fall. And exertional breath. And then when he walks, he can get breathless. So the cardinal three symptoms are chest pain, breathlessness, and syncope. That is, he can follow. So what are the physical findings? Is a good sized murmur, harsh systolic murmur in the aortic area, which is in the second intercostal space. Either it can be in the second right, or it can be also in the second left and a little lower. Basically in the second right intercostal space or a little lower. Basically, the length of the murmur does not predict severity. Basically, we need to know that there will be a harsh murmur. Sometimes it can be very, very soft and hardly detected. Sometimes it can be loud. So the loudness of the murmur does not correlate with severity. What correlates is length of the murmur, which is sometimes very, very difficult to appreciate. So now, this is very important for us to understand. Please look at this carefully. This gives us an idea of how dangerous this disease is. This is the latent period. 10 years, 20 years, 30 years, 40 years, 50 years, 50, 55, 60. When the patient becomes here, at this time, patient has become symptomatic. Once a patient with severe aortic stenosis becomes symptomatic, suppose their survival was 100%, immediately it starts to fall. And within 2, 4 or 6 years, most of the patients are dead. So please understand, this disease has a significant mortality, the mortality is more than for any aggressive cancer. Once a patient with severe aortic stenosis becomes symptomatic, we all need to take it very, very seriously, because see the curve, so many years have gone on. Once symptoms with aortic stenosis, symptoms starts, the mortality, the survival comes crashing down, and from 100%, 80% are 20% gone, 40%, 60%, 80%, and most patients die within a few years. Once symptoms develop, this is very important, once the patient develops either chest pain, breathlessness, or one episode of giddiness and syncope, it's very dangerous. It's important to remember, once patient has the average survival, once patient has angina, syncope is 2 years, angina average survival is 3 years, and once patient has heart failure or breathlessness, it is 2 years, angina it is 5 years, and syncope the average survival is 3 years. So once a patient is symptomatic with aortic stenosis, we need to act fast. What do we need to do? We need to order an echocardiogram. Echocardiogram will tell us whether it's tri-leaflet, bi-leaflet, what are the gradients, what is the valve area, how much it is opening, and how is the heart function. So this is an echocardiogram of an aortic valve. You see, this is the aortic valve. It is stenosed, and it's a systolic frame. This aortic valve should be wide open like this. It is not at all open. Usually this should be like this. And this is the gradient. Usually you get a gradient of less than 8 millimeters. Here it is 64 millimeters, almost 4 meters. Usually you get less than 1 meter gradient. Now, in severe aortic stenosis, the valve area is less than 1 square centimeter. I'll just show you I'll show you one video, and then we'll come back to now. Once a patient has once the diagnosis of severe aortic stenosis is made, what are the options? What are the options that we have? Severe aortic stenosis. Suppose he is asymptomatic, you can keep him on follow-up with an annual echocardiogram. Suppose he is symptomatic, something needs to be done. Something significant needs to be done. That valve has to be taken off. Once he has symptoms, either he has to go for surgery.
Sir, any other than systolic murmur, any clinical, because every physician here has the habit of putting the steth on the patient. Any clue that they have, because sir has told about echo in aortic stenosis. When should we suspect?
No, when any patient who presents with syncope, chest pain or breathlessness, we have to do a physical exam. On physical exam, if we get a murmur, and if the murmur is on the right second space or third second space, any murmur which is present and which is little long, immediately aortic stenosis should enter the differential diagnosis. The other findings are little difficult to appreciate if you get a left ventricular fourth heart sound or a third heart sound. In a busy clinic, that is not so easy to appreciate. If you get a little harsh murmur, little right upper second space or third space, or even the left third space, we must immediately think of aortic stenosis if the patient has symptoms and if he is little belonging to the elderly age group. So please feel free to ask some questions, otherwise you will go to sleep, I will go to sleep. So I think we must just casually, this is a conversation, this is not some didactic lecture. We are all together. So once a patient is symptomatic, aortic stenosis, this is a complex slide which doesn't have much meaning, it's very clear. Either this must be treated. Problem is, when the patient has severe murmur is there, you have diagnosed aortic stenosis, it is severe, but the patient is asymptomatic. That is the problem. Because how can you subject a patient who is asymptomatic to any procedure? You have to be very careful. So in such a setting, when the patient is asymptomatic, what we need to do is immediately we have to make sure that whether he is truly asymptomatic. Suppose there are some people who are 65, 70, they hardly walk. They go to their office in the scooter or car. They will be attending the office. Come, they will be sitting. They will be not going for daily walk or any form of exercise. They will say, I have no problem. That patient, he may not have a problem. He may be asymptomatic, but if you make him walk for 5 minutes or make him do a treadmill, he may become symptomatic. So the first thing we do is symptomatic aortic stenosis, immediately treat. Asymptomatic aortic stenosis, we have to make sure that they are really asymptomatic. We have to make them exercise, we have to make them do a treadmill, we have to induce symptoms, and if they are symptoms, then they go for the relevant treatment. So, I will just show you. This was the treatment which was being done 7 years ago or 10 years ago. The entire chest was opened. You can see the retractors. You can see the cannula going into the heart, and the patient's heart is defibrillated. It is stopped. Patient goes on bypass. The aorta is cut open. The valve is excised, and new valve is put. Stitches are taken. The chest is closed, patient is extubated after a few hours, patient stays in the cardiac surgical ICU for 2 days, patient stays in the ward for another 5 days, undergoes physiotherapy, rehabilitation, and then goes home. This is the travails of a 65 or a 70-year-old man. Now, what has happened in the recent past?
The everroot heart valve is a treatment option.
So this is the aortic valve which is opening nicely. This is just a video. You see the trileaflet aortic valve opening nicely. Over a period of time it has got thickened. Please look at this carefully. Thickened. It's opening less. You can see the change. And as it becomes more and more thickened, patient has aortic stenosis. This is just a cartoon. Patient is given anesthesia, local anesthesia. Patient is not given general anesthesia. This is done under conscious sedation. Conscious patient is awake. Patient is not asleep. He is given conscious sedation. Yeah. And then we put a small puncture is made in the femoral artery. A small puncture is made. Then when we make the puncture itself, when we make the puncture in the femoral artery, this is the femoral artery through the thigh. Before we used to do angiogram like this. Now we have stopped angiogram, we always do from the hand. We make a small puncture here. Keep the stitches also ready. We pre-close it. We take 2-3 stitches. This stitches is also done percutaneously. Without opening. There is no opening at all. This is the artery in the leg. We make the stitches, keep it ready. And then, this is the catheter which we take the valve in. This is a very simple, I'm just showing. This, we take the valve in, the valve goes up, then the valve is placed. This is the narrowed valve. Then we deploy the valve. We are not happy with the position, we pull it back and deploy the valve. This is the new valve. This is the new aortic valve, and the valve is opening and closing as you can see here. And the old valve gets crushed. This is the new valve, it is opening very well. This is what we routinely do for patients with aortic stenosis, degenerative aortic stenosis today. So that was just a cartoon. Now there are two types of valves. One is a balloon mounted valve and another is a self-expandable valve. I'll show you one case of each just to know. This is the story of a 64-year-old female who presented with exertional breathlessness. She was a diabetic, hypertensive, had hypothyroidism, hyperuricemia, and she had recurrent hospitalization for cardiac failure. She had a bicuspid aortic valve. She had severe calcific aortic stenosis. Aortic valve area was 0.27. Anything less than 1 is severe aortic stenosis. She had severe PH. Angiogram showed minus CAD. Surgeon offered aortic valve replacement, but she didn't want to undergo surgery. So this is what we did. Now, first thing we do is we do a CT scan. The aortic valve, we measure the aortic valve dimensions. We think the aortic valve is circular. No, the aortic valve is an oval structure. It has a minor diameter and a major diameter. So we take the measurements, measure the aortic valve, we measure the angle of implantation of the aortic valve, and then just to show you a case. What we do is we have punctured, this is the femoral head. We have punctured the femoral artery. We pass a wire, we cross the aortic valve. And sometimes we take a balloon, and this is very narrow. We take a balloon and dilate it and then put the valve. So this is our first catheter going up. During the procedure, we do something called temporary pacing. We pace the heart because the heart is a moving structure. When we cannot stop the heart and work. Otherwise, there is no point. I mean, the patient's heart has to beat while we are doing. But while we are implanting the valve, we need the heart. We have to implant it very, very carefully. Why do we have to implant it very carefully? There are 6 or 8 structures very close by. I will just go back to this. Tell you what are those structures which are very close by. This is the aortic valve. These are coronary arteries. The right and left coronary artery. This is the mitral valve. This is the left ventricular outflow tract. This is the sinus. This is the sinotubular junction. So anatomically, there are many factors which we must keep. While putting the valve, we cannot close off the coronary arteries. The blood supply of the right coronary arteries are very close by. So, what we do, we pace the ventricle. We put this is the temporary pacing wire. This is the injection to show the aorta. This is the aorta IV valve which is narrow. Why do we pace? When we suppose the heart now is pumping at, say, beating at 60, it beats like this. We want to make it stop, but we cannot open the chest and we cannot make it stop. So we put a pacing wire and pace at 160. So the heart now is pumping at, suppose it's pumping at 70, it's pumping like this. And at 80, it's pumping 100, 120, 140, 160. So in effect, when we pace the heart at 180 or 160, it's pumping like this, it is beating like this. So in effect, the heart is in standstill for that 30 seconds or 40 seconds that we need to implant the valve. So we put a temporary pacing and we don't switch it on. This is the aorta, this is the pigtail, this is a catheter which is immediately contrast. You can see this is a tri-leaflet valve. How can you know it's tri-leaflet? You see 1, 2, 3 cusps. Then after that, this is a wire. We use it to cross the aortic valve. Put a pigtail, and this is the first thing we do is measure the gradients. We measure the LV pressure. This is the ventricular pressure. This is the aortic pressure. You can see the difference. Can you appreciate this? This is one pressure which is so high in yellow. The pink is the aortic pressure. So there is a gradient of 20, 40, 60, 80, 110 millimeters. So this valve is very, very narrow. So first, since the valve was very narrow, we put a balloon. Can you see this balloon here? This balloon is across the aortic valve. We inflate it. So we make space. Now, this is the valve. The valve is going up. You can see the valve here. The valve is going up. It is going across the arch. Now we seat it nicely here. We seat the valve here. And once we seat the valve, this is the valve. We inflate the balloon and the valve gets seated. Once it is seated, this is the valve. This is a balloon expandable valve. And you see, I don't know if you have noted, now look at the gradients. There is no difference between the pink line and the yellow line. That means both the pressures are same and the valve is fully open. And this is what is at the end of the procedure. We don't open the femoral artery. While we puncture, percutaneously we take stitches around and we close it. This is at the end of the procedure. This is the incision around 2.5 to 3 millimeters on the groin, and the patient is sent to the recovery area, and the patient is ready to, he has a normal life.
So the sheath that you put in is not 6F sheath.
Is not
6F sheath.
No. It is a 14F sheath.
14F.
14F sheath. Actually, it is big. 6F now we can just give compression. That is why the femoral artery will have a 4 or 5 millimeter hole. We cannot leave a big 5 millimeter hole on compression and all that. So while putting the first wire, there is something called a perclose. We take stitches. That also is done. We can't see the stitches. It's an instrument which goes inside. We clip 2 stitches and we take the thread out and keep it like that. We keep it on both sides. Then we do the procedure. Once the procedure is over, we will just stitch it up. We'll close it and at the end of the procedure, this is what we will see. Patient does not need any compression, no external stitch is seen at all. Everything is, the stitch is on the femoral artery itself. Nothing is external. Externally, we will see this. And we don't even put a compression bandage. We put one small band-aid. And the patient is shifted to the recovery room. Patient stays there for some time. and then goes to maybe, nowadays we have safety, such an expensive procedure, we'll keep the patient for at least 6 hours in the ICU, then they go to the room. Now, what we saw a different type of valve. Now I'll show you one more case. This is the story of a 71-year-old male who had bypass surgery in 2002, angina. 2015, she had angioplasty to the RCA and the circumflex. Then patient again became breathless after 7 years. Patient had severe aortic stenosis. Angiogram showed all the grafts were normal, and this is what we did. Again, you see this is also tri-leaflet. One cusp, 1, 2, and 3. This patient had a severely narrowed aortic valve. We crossed the aortic valve, changed it for another. We put a very stiff wire in the ventricle, and this is the second. This is a different type of valve. First you saw a balloon expandable valve. Balloon was there, you pump the balloon, the valve opens up. This is a self-expanding valve, which means the valve is in a sheath. The valve is in a sheath. The entire valve goes through a sheath. So as you will see here, the entire valve is loaded here. This is the sheath. And we will remove the sheath. We have to take good landmarks and remove the sheath. As we remove the sheath, this valve will expand and it will sit. It sits very well. This is made from a metal called nitinol, nickel titanium alloy. This nickel titanium we have been using for ages together with during angioplasty. We use nickel. Nickel is put in all of these stents, stainless steel stents, nickel stents, cobalt, chromium, and nickel. So this is the valve. So this valve, we remove it, unsheath it, and it sits. This is the entire valve. And the valve immediately begins functioning. And the old valve, if you see here, it gets crushed to the side. And totally it is, because the sinus, if you look at the aortic sinus, is like this. It's a very roomy sinus. So the valve leaflets will just fall on the side, and the new valve will immediately become immediately functional.
Sir, won't the valve leaflet close the coronaries?
See, that's what is very important. That's why I told you that the aortic valve, the aortic root, that itself is like the anatomy of that is huge. So for that, what we do, for every case, we do something called planning. This is the most actually doing the procedure is not very difficult. The most important thing is planning. So you look here. Now, this is the planning sheet. This is one page of a planning sheet. This is this is the first page of the planning sheet. What all do we measure? We measure the annulus, the size of the aortic root, how big it is, the minor diameter, perimeter, area. Then this helps us choose the size of the valve. If you put too small a valve, it will drop in. If you put too big a valve, it will not sit at all. So we have to choose a proper size. So this is the first. Then we look at the height. This patient's height is 10 millimeters, 10.5 millimeters. Usually most of the heights are 12, 13, 16 millimeters. 12, 13, 16 millimeters. Anything above less than 10 millimeters, we have to be careful. Anything below 3, 4, we should stay away. We should not do it, because the valve leaflets can go and crush it, or the device itself can occlude the coronary arteries. If the device occludes the coronary arteries, it means we are causing an attack on the table. But most coronary arteries are above 10 millimeters. We measure the left coronary artery here is 10 millimeters, the right coronary artery here is 13 millimeters. Then the sinuses, that means the sinuses which are huge, 30 millimeters, 26, on 26 on this side, 30 on this side, 33. So the valve leaflets will go and open and sit like that, and they will be out of the way. You will be amazed to know how in detail we study the anatomy on a CT scan. Like it's like a surgical procedure. We measure every single point. And then only the success of the procedure is not in the doing. The success of the procedure is in the planning. How much time we measured, how carefully we measured all these diameters. Otherwise, actually pushing this valve inside is something which is not very, very difficult. As you rightly said, we have to make sure that we do not obstruct the coronaries. So these are the problems which can occur. And then here the bundle, his bundle goes in down. So we have to keep that in mind and look for conduction abnormalities also. So that's a very good question. We make sure we do not obstruct anything else. Like for us, the aortic valve is not a small valve like this. For us, it's like a building. It's like a building, huge sinuses, one pump here, right coronary artery, left coronary artery here, our valve will sit here. So you make all the measurements and make sure that we do not obstruct anything. Then the conduction system is going there, the membranous septum, the mitral valve is close by. So we measure every single thing. We'll spend 1 hour on CT scan, on analyzing the CT, and the procedure actually may be even less than that. Procedure is more in the making sure that we don't damage the femoral artery, we open it carefully, stitches are purpose, there's no bleeding. Procedure actually is much less, any procedure is significant, but the real success of this will be in the planning. What happens before the patient enters the cath lab? So as you rightly said, it's a very important question. So this is why I showed you, these are all the CT images. You are measuring, this is tri leaflet, measure all the diameters, then take an average, then choose the size of the valve. So we have to choose the 23 millimeters, 26, 29, 34 millimeters valve. So this is a pre-gradient. You see the yellow line is high, the yellow line is here, LV, the pink line aorta is here, and after the procedure, it is here. Initially, a few years back, we used to do it under general anesthesia. Now, there is no general anesthesia. This is the advantages. Patients having severe COPD, patients with bronchial asthma, poor lungs, we don't ventilate. Even normally also, we do not ventilate these patients. It is conscious sedation. This is a team effort wherein the anesthesiologist is a very important part. His role is to make sure that the patient does not go under anesthesia. Today, anesthesia on the propofol, propofol, they'll give one that white propofol, they'll give some sedation, some midazolam, we'll give local. Patient will be awake, he'll be nicely sleeping, but he'll be fully awake, he'll be breathing on his own. It's very important that these old patients, once you intubate them, then that is when the problem occurs. Extubation, pneumonia, aspiration, all those problems start. This is, as I told you, at the end of the procedure, the groin. And this is an example of a fully deployed valve. After each time, after doing the procedure, we look at the femoral artery. We have to show that we didn't damage it. So from the other side, we will show this. We'll make sure that if you look carefully here, this is the femoral artery of the patient. This one. So we have to make sure then that everything is clean and there is no problem. The patient is then shifted and this closure is done through a device. This device also, it will take the stitches from the femoral artery. We will not even see the stitches. We will only be able to see the threads. Then we'll push the stitch inside. We cannot even see the stitches actually. We will only see the two threads, and even the stitching is done blind. The entire procedure is totally percutaneous. So to summarize, for patients with aortic stenosis, listen for the murmur, order an echocardiogram, and if it is significant, then further evaluation needs to be done. TAVR is a non-surgical treatment option for patients with severe aortic stenosis, at patients with high risk for surgery, at intermediate risk for surgery, or patients who are even low risk for surgery. Anybody above 50, 55 can opt for this form of therapy. So I'll be happy to take any questions or any doubts or any way I can clarify something. Yes, because these valves are made from porcine material. They are not metallic valves. They are tissue valves. So whenever there is a tissue valve, the tissue has a life. 12 years, 15 years, 18 years. So if you put a 45-year-old man, 40-year-old male, he can opt for it, but we will not suggest it. 40-year-old man, we will tell him to go for a metallic valve. That metallic valve will last. Otherwise, after 20 years or 18 years, he has to undergo one more surgery. So this is only tissue valve. We cannot implant a metallic valve like this. So that is why it should not be done in 40, 45 years. 40, 45 years for potona, again at 60 years to go, 60, 40 years, then at 60 years, one more procedure. The valve tends to degenerate after 15 years, 18 years. So that's why it's not advised in younger people. It's a metallic valve, which will last.
I am Dr. Sanmugam, urologist. You may think why this man is coming and talking in a cardiology meeting. I am here only because of Dr. Rajpal. So 2 years before I had chest pain and the angiogram revealed the multiple blocks. So everyone advised a CAPG for me. So I consulted Dr. Raj and requested him to think about doing a angioplasty for me. So after 2 days he said, okay, I will go ahead with that. So he did a marvelous job. I am here only to thank him, and I thank Dr. Saravanan also because he has not come to Erode IMA for a long time. So this is the right time he has brought him. But I think most of the patients are not here. He is the best known interventional cardiologist as far as the angioplasty is concerned in our South India. So I congratulate him and I thank him for giving me an opportunity to stand before you now.
Thank you, sir. Thank you.
Thank you very much.
நான் முன்னாடியே சொன்ன மாதிரி சாருக்கு நம்ம ஏரியாவிலிருந்து மட்டும் ரெஃபரன்ஸ் கிடையாது. டெல்லியிலிருந்து நான் சாருக்கிட்ட டிஎன்பி கார்டியாலஜி பிஜி இருந்தபோது டெல்லியிலிருந்து டு டாக்டர் ராஜ்பால் ஃபார் லெஃப்ட் மெயின் ஸ்டென்டிங் அப்படின்னு போட்டு நான் இருந்த பீரியட்லேயே 4-5 கேஸ் ரெஃபர் ஆகி the patient will be transported from Delhi to Coimbatore to undergo his procedure. So that is Dr. Rajpal.
Sir, what is the youngest age you can do this procedure, sir?
Youngest, sir? Sir, we can do for younger patients. In fact, younger patients, it is more easy for us to do it. Avada calcium irukadu. But younger patients, we do not, 40, 45, we do not advise them to undergo this. Because what will happen after when he is 40? What will happen when he is 60? The valve, it is the tissue valve. So youngest we would like to do is
Congenital aortic stenosis, critical.
No, sir. Congenital aortic stenosis, if the patient is less than 55, less than 50, we don't advise this. We advise them to go to the conventional.
Children we don't do.
Children, no, sir. Better not, no. Because how can we do the child? This is for adults.
Yes.
Not for children, sir. Not for children. No.
சார் ருட்டீனாகவே இந்த அயோட்டிக் வால்வ் ரீப்ளேஸ்மெண்ட் பண்ணும்போது வந்து the most of the conventional aortic valve replacementல it will be done with CABG. இப்போ வந்து is that any do you usually perform a pre-procedure conventional angiogram?
Yes, certainly. We will do an angiogram, then we have to sit and talk to the patient. He is 65, 70 years old. We tell him, okay, you have one block and you have aortic stenosis. Do you want to undergo surgery and aortic valve replacement? You can opt for that, but the risk will be so much. Or we can do the angioplasty and replace the valve at the same sitting. So we...
Angioplasty first, then valve replacement.
Sir, nowadays, nobody is interested in waiting. I'm just telling you the trend I'm telling. The son will be, he'll be doing IT somewhere, or he would have come from US. This is the... So, most of them, they want to finish it off and go. But technically, what we do is, what we keep in mind, always safety first, safety first. We're doing angiogram, first we have to do CT scan. CT scan photo, contrast is used. You are a nephrologist, contrast use pananga. Angiogram na contrast, angioplasty contrast. So we are very careful. We try to give a gap between the CT scan and the procedure. Adu konja gap kadchide 1 week, then we can do angioplasty and valve replacement together. Suppose that gap is very small, then we tell them, see, it's better that you have the angioplasty, wait for 3 days, 4 days, check the creatinine, because these are all old people, 65, 70, then we do the...
Usually there can be a coexisting renal artery stenosis also in all these cases, atherosclerotic valve heart disease.
Absolutely.
And usually sir will usually do the complete the conventional angio within 15 to 20 ml of contrast. That is his main...
You are very careful.
He uses...
We are scared of the nephrologist.
He uses, at that point of time I was in cardiology, but he uses the most lowest volume of contrast for both PTCA and angiograms. And what about the conventional, that is there any renal artery stenosis stenting also will you do at this juncture when you do a conventional pull-through angio of the abdominal aorta?
Unless it is, if it is not severe, if it is minor, then we don't touch it. If it is only severe and it is demanding something, then only we will.
Coronary cusp fusion, any importance of fused coronary cusp?
Fused. Yeah, so if, because these cups, when they are fused, first thing I showed you one balloon, no? Dilatation. When we put a balloon and dilate it, it will break those fusion points. Then only it allows us the space to put the device inside. See, I don't know, is that the question?
I have a patient with a 60 years old male with severe aortic stenosis with gradient 97.62 with concentric LVH, asymptomatic, with the fused right coronary cusp. That's what the...
Yes. Oh, fused, right. Fused right coronary cusp means it's at Siever's type 1, right-left fusion. This is a patient whom, if the gradient was?
97.
Yeah, now, this will be for severe, this can undergo TAVR. Because the cusp will fuse, then only the gradients come. But the thing here is, you have used one important word. He is asymptomatic. The problem here is, one, you have to assess whether he is genuinely asymptomatic. That means, if he is climbing one or two flights of stairs and he gets breathless, then he is symptomatic. Suppose he is not doing any physical activity and simply sitting at home, he may be actually symptomatic, but his symptoms are being hidden. The aortic stenosis is such a disease, it will constrict all the activities. Before he used to walk to temple, slowly will stop. I feel tired, sir, I am not going to temple nowadays. I am happy, I am at home. So you have to decide whether he is truly symptomatic. Second thing is, when the gradient is 64, it is severe. Once it crosses 90, it is critical. And in critical patients with aortic stenosis, the incidence of sudden cardiac death without symptoms is so high that in patients with critical aortic stenosis, they are offered this procedure to prevent sudden cardiac death.
So, asymptomatic patient should be evaluated in the beginning itself.
Yes.
To plan for the procedure.
Yeah, absolutely.
any anticoagulation is must for this lifelong anticoagulation?
Yeah, yeah.
If yes, what molecule you prefer?
Yeah. No, we prefer aspirin is fine. Just ecosprin 75 milligrams.
Anticoagulation is
No,
not necessary.
anticoagulation is not required. No anticoagulation. That's the advantage because it's a bioprosthetic valve. It is not a metal valve. It is a bioprosthetic valve.
So it will be very difficult to convince the young patients with a conventional type, right, sir? Because if they ask for it, suppose if a 35-year-old, 40-year-old aortic stenosis patient asks and pushes you for this procedure.
I should not be saying this. I cannot quote a name. But there is a very, very famous cine star lady. She said, she had congenital bicuspid aortic stenosis. She's a very famous lady. She comes in all Tamil movies. So one day we got a call from Dr. Sendil Balaji, a very senior minister, that this lady is coming there. You please look after. We thought usually they'll have atypical chest pain. Onnume irukadu, mitral valve collapse. You just go away. She came with all her reports. She had congenital aortic stenosis, bicuspid aortic valve, which is a very narrow stenosis. So we explained to her, and she actually, in one of the important movies which has been released in the last 6 months, while dancing, she fell off. She was doing the dance and she fell. That is when she came to know that she had aortic stenosis. So immediately she came here from Chennai, she came here. And we told her, you need this, you need aortic valve replacement. We told her, you need open aortic valve replacement. She said, no doctor, I will never get it done. I cannot take the scar. People will know I am this one. If you are willing to do anything without the scar on my, because they have to wear dresses and so many things, no, they said, I will not take the scar. So then we convinced them, we called the parents. We told the father, sir, she's an actress, I agree, but what is more important in life? Please put in a metal valve, go for surgery. She refused. We tried 3 sittings we had. Then we counseled, then she said, no, I cannot have this, and she told the reasons also. I am an actress. I have to wear very nice clothes. Ingella therinja, scar or any scar is there. Then we told her we will do small mini thoracotomy. Mini thoracotomy, a surgeon came and explained to her, we will do mini thoracotomy, it's a small scar. She said, then I cannot wear bikini. Adaliyum konja theriyum. So finally, 2.5 months back, we did her aortic valve replacement. She was 33 years old. She's a very, very, very famous cine actress. And we did it and she's fine. But that is something which we do not recommend routine. Because they should go for a metal valve. Because 33, at 53, she has to go one more procedure. Then at 73, one more procedure. So usually it's above 50.
Is there a possibility for a reprocedure after this?
Yes, certainly. I will show you that.
Suppose if this valve goes into stenosis after some time.
We replace the valve.
You'll take out the old valve?
We don't take it out. You understand, if you look at the valve picture, it is only nitinol. Nitinol in the valve. The nitinol thickness is how much? Less than 0.5 millimeters. Less than 0.5. The thickness of the valve. So 0.5 on all sides. That's all it is. And then the valve deflates. We put in another valve. This valve will sit in that valve. And this will open out like this. For us, the aortic stenosis, the aortic valve is like I told you, it's like a building. These are the huge sinuses. And the valve is sitting here. The valve is sitting here. And these are the sinuses. So we have enough space to do things. So we replace the valve. Means we put one more valve inside. But we have to be cautious. We have to make sure we don't obstruct the coronaries. And we must leave future like this lady. We told her, explain to her why. We told her, what if you get a heart attack after 10, 15 years? So we got a special valve which is very short, which we can easily access the coronaries. So that nowadays, we have to get it because that's a little more expensive valve. It's a Evolute Pro FXL. That costs much more. So we got that valve for her, wherein it will be easy to access the vessels of the coronary arteries when if she develops. We told her 20 years later, 30 years later, you may develop some problems.
From the surgeon's point of view, post this procedure, can you safely stop the antiplatelets to undergo procedure like kidney transplant if we can?
Absolutely, absolutely. It's aspirin, no? Ecosprin we stop for 4-5 days or 1 week. In fact, nowadays, of course, people are doing procedures on aspirin also, but we can safely stop. No problems. No problems. Because this is a tissue valve, this is not metal. The cage, only the cage is metal. Do you understand? Only the cage is metal, and the cage is a very thin leaflet.
The patient already underwent mitral clip for severe MR.
Yes.
The patient later they find out severe aortic stenosis. Whether they can go for the...
Absolutely, because you can see that it's a separate valve. The path itself is different. Yes, certainly.
When I was in JKNM, one of the father of a famous cardiologist of Europe was admitted with Dr. Rajpal and has underwent the stenting. And to share my experience, sir the usual patient of sir will have this much big file because he is the tertiary care cardiologist. Because before the patient reaches him, the patient would have met lot of cardiologists, and he usually spends time in going through the entire case sheet, and he will make the DNB cardiology PGs to go through each and every page and put a notes. It is an elaborative notes that he does, and he gives a lot of importance to the clinical examination, and usually he will start the rounds by around 8 o'clock in the night, and the rounds gets completed by 11:30, 12 o'clock. So he spends at least 10 minutes in each room, and when he first sees the patient, he won't miss the pulsation, dorsalis pedis in both legs. There are many lessons that he teaches the students, and he usually calls us doc. He will ask us to accompany his rounds that starts by 8:30, that goes on till 11:30, and we both will go for a short dinner and restart the rounds. If you see the cath lab notice board, the notice board will be 80% to 90% consumed by Dr. Rajpal sir's patient of JKNM cath lab. So averagely he does around 20 to 25 stents on a day, and many lessons he has learned, he has taught us, and the way he does the procedure and the steps he explained to the patient's attenders is really awesome. And as a nephrologist now, though I am in a different division practicing now, and at one point of time there was a donor in our hospital. That donor was absolutely normal in pre-transplant evaluation. So this patient was intubated, and after the intubation for donor nephrectomy, this patient developed left bundle branch block. So new onset left bundle branch block. So at that point of time, I somehow remember Dr. Rajpal sir, and I made an emergency call to him. Sir, patient has been intubated, the transplant recipient is open, that is bed preparation is started. So at this point of time, if I am going to consider this left bundle branch block as a acute coronary syndrome equivalent, I have to shift the patient to a cath lab, complete an angio and go on. And even at that time, I just called Dr. Rajpal sir, and he guided me in a right way. That patient is still doing fine. Sir, you remember this? That was before some 1.5 years, on a Friday afternoon, 2 p.m. Sir usually attends the call, and even if he is not going to attend the call, his physician assistant will usually, Appa is also usually, நீங்களும் பேசுவீங்களே, பேசித்தான் ரெஃபர் பண்ணுவீங்க sir. Usually, sir attends the calls from the referring physicians, and the importance he gives to the referral physicians is really one lesson that we have to learn from you.
Sir, one last question. So, in a tertiary care, what are the specialties like when you have the severe calcified coronary arteries? What are the technologies you use in your cath lab?
No, in the cath lab, we have
many cases with severe calcified.
Yeah, if the vessel is truly calcific, then we use various techniques. One of them is rotablation. That is, we use a high-speed drill at 170,000 revolutions per minute. The drill is a metal drill in the coronary arteries which has diamond chips embedded. So it will shave off all the calcium. That is one. Then we have intravascular lithotripsy, like how the nephrologist uses, no, for breaking stones. So, I mean the urologist, sorry, sir. So like that, we have for the coronaries also. We have a balloon which will deliver shocks and it will break the calcium. And then once the calcium is broken, we put do the angioplasty and do the stenting. So these are all options that are available.
Thank you.
So still left main stenting,
Yeah, we are doing routinely, goes on.
many patients.
Actually, we had one very unfortunate incident from here. A patient came from Erode. Patient had severe aortic stenosis and coronary artery disease. The angiogram was done in Bangalore NH, some big place in Bangalore, and the catheter was sitting inside the left main. The left main was narrow. The catheter was inside, so everything looked normal. So they told him, we have normal coronaries, and he went off. He went into pulmonary. He came here, we saw this, we did the angioplasty for the left main, and we told him everything is good. Now we have to do the aortic valve. So we told him, you go back, you have used too much contrast. You have the choice of going back or staying here for 1 week. Patient opted to go back. He developed pulmonary edema due to aortic stenosis. Then he was rushed and finally it was done, but it became a big, for that in our hospital we have a protocol. When a patient goes and is readmitted within some time for any procedure related, we have to, like this, there will be a meeting. We have to answer a meeting. Then we have to explain. Then we explained to the patient, either you stay in the hospital for 1 week for the contrast effects to go away, because he has had CT scan, angiogram, angioplasty. Angiogram outside, CT scan and angioplasty here. And then, so we waited and waited. He opted to go home and come back. So he went into pulmonary.
From the nephrologist point of view, sir, when I was in cardiology, we were very much scared about this acute kidney injury.
Correct.
But after I stepped into this nephrology practice, the importance that we give to acute kidney injury in avoiding a procedure with a contrast-based procedure, if by avoiding that procedure it is going to produce a life-threatening event for the patient, maybe at that time we can take a decision to safeguard the life. And even if the contrast-induced nephropathy happens and patient lands into dialysis, it is a temporary event.
Correct.
Maybe some 1 or 2 dialysis the patient comes out. But if the heart goes out, the usual quote that I give in my usual kidney transplants is, if kidney goes into failure, we have dialysis and transplant. But if the heart goes into failure, the heart transplant and all other things are very tough.
It's not easy. But still, we are very careful. We like to space it a little, because if the kidney goes, 1 or 2 transplants, ICU, sepsis, infection, that whole we are. But still, when you are forced to do it, and after that we are very careful actually. Safety. First thing is safety. Patient should not have complications. Patient should not have problems. Yes, sir. I was waiting for this question. This is the weakest point, sir. In this whole story, the weakest point is the cost. Before it used to cost 26 lakhs. 26 lakhs. Now it has come down to 18, 15, and Indian valve we can do it for in little less also. But now what has happened? Now listen to this, how the dynamics of the equation happen, how the industry responds. Before, there were 3 manufacturers of the surgical valve. Surgical valve used to cost 1 lakh. 90,000, 1 lakh, 1.1, 1.2. The best valve 1.2. All over the world, because of this TAVI, the surgical valve numbers have come down so much, 2 manufacturers have closed down. There is only 1 manufacturer of surgical valve. His valve now costs 3.5 to 4 lakhs. You add that to the other, I'm talking about the good valve. Add that to the other expense. The surgical costs have now jumped up. So that margin is, before the margin was so much, between surgery was here and tower was here. Surgery has gone up and it has come down. So, but still it's expensive. I don't say no, sir. It is expensive. It is quite expensive.
Any insurance backups for these,
No, there are 2-3 options. One is, one valve, they allow us to implant the valve, but they'll take an undertaking from the patient, some amount he pays, and then on an annual basis he has to complete his...
CM scheme, sir?
No, CM scheme illa. This is industry. CM scheme, they would...
After placing the valve, and how many days the cardiac hypertrophy cells, like it will get back to normal, sir?
Yes. Now the question is, patient has aortic stenosis, the patient has developed severe hypertrophy of the left ventricle. After placing the valve, how long will it take for the hypertrophy to become normal? Many a times, it will never come to normal. It will regress over a few months to years. If it was, say, if it was 25 millimeter thick, normal is around 13 millimeters. If it was 25, it will become 18 or 17. It will never get to normal because, as I told you, along with that hypertrophy, some fibrosis is fibrin material, it won't come to normal at all. But that's enough. It doesn't matter. Yeah, once the valve is placed, pressure overload comes down, so immediately the muscle will start to become thinner, but it never comes to absolutely normal.
Aortic regurgitation severity, whether it has any say on this selection of this procedure?
No, before we used to not do this for isolated severe regurgitation because in aortic regurgitation, the calcium is there and the narrow valve is there to hold the new valve. In regurgitation, the valve is leaking, so we have to put a very, very big valve. So with bigger size, we oversize the valve.
But this valve will prevent regurgitating.
No, this valve will seal everything else,
yes,
and the new valve will be competent. It can be used. Certainly, it can be used in isolated AR, but we have to be again planning. We have to oversize the valve. Narrow valve, we put a valve. That narrow valve is calcium. It will catch it. But you put it.
So these planning, where it happens, sir, by the cardiologist or by the radiologist?
No, radiologist doesn't. By the cardiologist.
But the CT scan is done by the radiologist shoot?
Yes. The CT scan is done by them. We take the CT scan.
Packs.
No, not packs. No packs. Packs, no. We take the original CD.
Original CD and then go.
Then the software for this, the software for this Trimencio software is 15 lakhs.
Okay. So the software will...
The 15 lakhs is the cost of the software. If you want to put that software inside of my personal computer, it's 15 lakhs. They won't give it. So unless it's all, whatever it is, that's what it is. Then we have to sit, go through all the cuts, make measurements. We will do it alone once. Then there is one fellow from the industry. He will do it. We'll sit together and then. But nowadays it's all routine. The software is very powerful.
And sir, also, when we were there, many of the employees of GKNM, he has been doing this PTCAs and angiograms at such a nominal cost, and he puts the stents free of cost. So usually sir gets some, he will always have some 2 or 3 stents, and if any person from the employee side, if they are really very poor, they cannot afford the stent. Sir just puts the stent free of cost for them, and there is a separate fans. Sir has the highest fans of the JKNM employees. So
It's our duty. We are working in that hospital for 20 years, 25 years. Because when people come to us, we have to respond. We can't leave them hanging there.
yes, so very wonderful talk. Any more questions? So we will honor the speaker. We request Dr. Tangavelu, Dr. Ayyavu sir to join the rise for honoring the speaker. Erode IMA is really honored to have you, sir, here on this Sunday evening. And in spite of your busy schedules on the weekdays, you have taken much pains to develop all these slides, and you had come here. And once more, to enlighten all of you, sir, please take the dice. And we are going to face Tamil Nadu Medical Council election. And our Erode IMA senior member, Dr. C.N. Raja, is contesting for the TNMC election. And this is the video that I want you all to watch. So coming to the vote of thanks, we really thank Dr. Rajpal and other dignitaries on the dais, off the dais, for attending this monthly meeting. So this is the November month meeting. In my period, we have another 1 month more, and next month Onco Foundation has been taken as an academic speakers for the next month. And the date for the next month monthly meeting will be announced shortly, because of we having a state council meeting that is going to be held on December 18. That is when we usually run this IMA monthly meeting on third Sunday of every month, and dates will be announced shortly. And we are also planning for a New Year event that is to be conducted in this hall. And January 8 is the installation of the next team that is also planned for now, and the same will be communicated in all the official groups of Erode IMA. And we will go for the national anthem now, and then we will part. And we have a cocktail dinner that is planned for today, and we will have the dinner in the basement.